Dear friends and colleagues, welcome to the fourth CSRS Europe webinar. I hope you are all healthy and in good shape. Along with Philippe Bancel from Paris, CSRS Europe past president and board member, will be chairing this session. And I have Luiz, who's based in UK, as our webinar host. We have today a webinar on not so hot or sexy, often forgotten topics in cervical spine disorders and surgery. Actually, the idea of this webinar came when last spring, when Dan Ryu proposed me to present a lecture on the value of radicular pain in localizing compressive pathology in cervical spine. And my reaction was, why to spend educational time with a rather simple issue instead of more complex and high-tech ones. But then I thought more about that, and I realized that Dan was right. And I started to imagine other lectures about topics that we consider too simple to even deserve attention, or techniques that are nowadays considered obsolete or not fashionable at all. We were very lucky to get an outstanding lineup of friends and masters of cervical spine surgery that accepted the challenge to elaborate on this blunt but very important, as you'll see, topics. At the end of each lecture, there will be questions submitting to polling to make it more interactive. Also, the participants can raise questions in the chat, and Philippe and I will bring it to the stage. So without further delay, I would like to introduce Dan Ryu. Dan doesn't need formal presentations. He's Mr. Cervical Spine. He does only cervical spine, as I understand. He's a professor of orthopedic surgery at Columbia University in New York. He served as past president of CSRS North America, and is the chairman of the International Board of AO Spine. His lecture is on the importance of radicular pain in localizing compressive pathology. Please, Dan, go ahead.
Thank you so much. It's great to be with everybody, at least by Zoom, if not in person. And I'm going to talk today about how you localize cervical radiculopathy levels based on what the patient is complaining about. These are my disclosures. I do get some royalties on an anterior cervical plate and own some stocks and companies. So this is a series of questions and answers. And the first question that I have is, which finger is never a C7 dermatome? So if somebody comes in and says, my small finger, my ring finger, my long finger, or all of my hand is numb, are any of those a C7 dermatome, or any of those never a C7 dermatome? And as you think about the answer, the C7 nerve root comes out, and in the brachial plexus, it actually branches out to have parts of itself in the median nerve, the radial nerve, as well as the ulnar nerve. And this may be why the real answer is that any finger can go numb with a C7 radiculopathy. I've seen patients with the first three fingers, the next three fingers, the last three, the last two, the long finger, the index finger. Any one of those can be a C7 dermatome. The next question is, which level causes pain in the axilla and over the anterior chest? So is that a herniated disc at C4, 5, 6, 6, 7? Could any of those levels give you pain in that region, or does it have anything, maybe it's got nothing to do with any cervical pathology? The answer is C6, 7. This is a very, very common finding with C6, 7. I would say somewhere in the neighborhood of 60 to 70% of patients who have a C7 radiculopathy have this. And I was in clinic this past week with my fellow, and my fellow had never heard of this before. And we saw three patients. All three of them had a C7 radiculopathy, and they all complained about pain in the axilla and the anterior chest. And by the end of that clinic, he was absolutely convinced that this is a very common finding. Which level causes pain that goes up behind the ear and into the temple and behind the eye? Is it C1, 2? Is it C2, 3? or is it most commonly C3-4? And this is also another very common kind of radiculopathy that I didn't know about until I heard a presidential guest lecture when Bruce Northrop was president of the Cervical Spine Research Society in the US, maybe about 25 years ago. And the answer is the C2-3 level. It often is due to facet arthrosis at C2-3 causing foraminal stenosis. And you can often do a foraminotomy or an ACDF or a posterior cervical fusion, and this pain will be alleviated. We wrote a paper on surgical treatment of high cervical radiculopathies that showed that a lot of these patients will have headaches and retroauricular pain. And we found that surgery was highly effective at getting rid of those types of headaches. And if it has foraminal stenosis as the main component of why you have that pain, and it gets worse with the Sperlings, you can do a nerve root block. And if that doesn't work long-term, you can do a foraminotomy. Next question is, which nerve root deficit will affect your grip strength? Which nerve root will lead to weakness of your grip? And we're typically taught that it's the C8 nerve root. But is it A, 5, 6, or 7, or B, C8, T1, or is it C, all of the above? I have one of these dynamometers, and it's actually very inexpensive in the United States. And the answer is all of the above. I use a dynamometer on every patient, and you'll see patients with a C5, C6, C7, C8, T1 radiculopathies. And they all have weakness of the grip because they do affect the forearm muscles. It can affect the upper arms, and it can lead to atrophy regardless of what level you have weakness in. Now, clearly, if you have a profound C8-T1 radiculopathy, it's going to give you the greatest degree of weakness, but you'll still see some weakness even if you don't have a C8-T1 radiculopathy. Which level causes pain in this region? This is the spine of the scapula, just medial to the spine of the scapula. And this is also a very common finding. And is it C5, 6, 7, 8, or is it a thoracic level that causes pain here? And when I first started in practice, I just assumed this was a thoracic level. It was just too low, or it was just a non-specific pain generator and it had nothing to do with a radiculopathy. I used to think this was facet-based pain because many textbooks say this is facet-based pain. Well, it turns out this too is a C7 radiculopathy. And the next time you see a patient with C7, ask them if they hurt here. And again, 70, 80, sometimes 90% of patients with a C7 radiculopathy will say they have pain right in that region. And again, the same fellow, the same week, all 3 patients had pain in the axilla, the anterior chest, and right in that region, as well as other manifestations such as triceps weakness. Very common finding, and patients find this to be an excruciating point of tenderness. Now, which is not likely to be a cervical radiculopathy? Somebody who says I have weakness of the shoulder external rotator, or somebody who has a weak shoulder internal rotator? One of these is commonly seen with a typical cervical radiculopathy, but the other one is almost never seen. Is it A, a weak shoulder external rotator, or B, a weak shoulder internal rotator? Well, let's look at what causes you to, what allows you to do a shoulder external rotation. It's the deltoid muscle, the infraspinatus, and the teres minor, and they're all innervated by C5 and C6. So if you have injury or if you have a deficit of C5 or C6, you'll have weakness of shoulder external rotators. So this clearly is a common cervical radiculopathy that we see very, very often. However, shoulder internal rotators are innervated by a lot of different muscles. The anterior deltoid contributes to it, the subscapularis muscle, the teres major, the latissimus dorsi, and the pec major. They all contribute. So in order to get weakness of shoulder internal rotators, you often have to have a deficit of C5, C6, C7, C8. All of those have to be out. So either you have a brachial plexopathy, or more commonly, you've got a problem with an internal derangement of the shoulder. Either they have an arthritis of the shoulder, or they have a massive rotator cuff, or something else that's causing weakness of shoulder internal rotators. So if you see someone with weak shoulder internal rotators, don't suspect that you have a cervical radiculopathy, especially if they have a normal biceps and triceps, wrist extensor, flexor, finger extensors, and finger abductors. If those are normal, the patient does not have a cervical radiculopathy. So the answer is shoulder internal rotator is not likely to be a cervical radiculopathy. How about this? Is this a patient with cervical radiculopathy? They have weakness of pronation. They have pain in the radial forearm going into the thumb, and they're numb in the thumb, index, long, and part of the ring finger. They can't pinch with their thumb, and so they have weakness of the distal phalanx flexor of the thumb. Is that a cervical radiculopathy? Yes or no? This is actually no. It's a pronator teres syndrome. It can often mimic a cervical radiculopathy. And I know patients who have had an ACDF at the C5-6 level because the surgeon thought that this was a C6 radiculopathy. If you have all of these together, the flexor pollicis longus, and you've got numbness in this distribution, you have weakness of the pronation. If it's a radiculopathy, you're going to have to say that the patient has a C6, C7, C8, and a T1 radiculopathy to give you this combination of nerve and pain and sensory and motor deficits. And clearly, you're not going to have a C6, C7, C8, and C8 radiculopathy. So just think of pronator teres syndrome. It is not that common, but it is present, and you need to understand that it can mimic a C6 radiculopathy, especially if you don't check for a Frohman sign, which allows you to do this, which you can't bend at the thumb, so you end up doing something like that. And it is not an anterior neurosseous syndrome, which can also present with similar symptoms, because with that, you don't get numbness, there's no pain in the forearm, and there's no weakness of the teres, pronator teres muscle. So the answer is it is not a cervical radiculopathy. This is a pronator teres syndrome. How about numbness in the forearm over here? Is that due to an ulnar nerve problem at the elbow? Is it a C8, T1 radiculopathy, or is it a T1, T2 radiculopathy? And if you take a look at what the ulnar nerve does, if you cut the ulnar nerve at the elbow, you only get numbness in the dorsal part of the last two digits and the palmar part right to here. If you cut it at Guillen's canal, you get numbness right only here, but nothing proximal to the wrist. And that area is actually innervated by the medial antebrachial cutaneous nerve, and the medial antebrachial cutaneous nerve comes anterior, not behind. So even if you cut the ulnar nerve, you will not get numbness in this area. And therefore, the answer is a C8T1 radiculopathy causes numbness in that area, because it's the medial antebrachial cutaneous nerve as well as the ulnar nerve, both of which come from C8 and T1. Which nerve extends the fingers? And is it C6, C7, C8? Is it A and B, C6, C7? Or is it E, B and C, C7 and C8 that allows you to extend the fingers? And this is a good muscle to test, because if you're testing other muscles, people are very strong, but the finger extensors, most people aren't strong enough and they can't quite resist. So you can tell when somebody has very subtle weakness. So the finger extensor muscles are the extensor digitorum communis, which is a branch, it was just innervated by the posterior interosseous nerve, and that's a branch of the radial nerve, which gets predominantly its effect from C7 and C8. The extensor digitorum communis extends the metacarpal phalangeal joint, but the inner phalangeal joint, it's the lumbricals and the interossei, and that's C8 and T1. And therefore, the answer is that if you have a C7 deficit, you'll get weakness here. If you have a C8 deficit, you'll get weakness here. But because C7 radiculopathies are much more common than C8, you will see it much more commonly with a C7 radiculopathy than a C8 radiculopathy. But know that both nerves can lead to weakness of the finger extensors. And those are just a few of the questions that I thought that it would be good to review for surgeons examining patients with cervical radiculopathy. And I've given this test in many different settings, and I can tell you that that the vast majority of spine surgeons don't know this neurology, but it's very important to learn, and you'll see it over and over again in your practice. So thank you so much for your kind attention today.
Dan, thank you so much. I'm smashed by your presentation. And I think, especially for the young people in the audience, it's really a positive message. People need to extract the most from semiology and from neurology. So in line with this presentation from Dan, we have Professor Takashika Shimizu from Japan. He's our good friend from Japan. He's Chief Spinal Surgeon and Director of Guna Spine Center. He's President of CSRS Asia Pacific and President of Japanese Scoliosis Society. It's a great pleasure to have you on board, and you will see more about this surgical neurology that is so important to have in mind. Please, Takashika.
Yeah, thank you. So I'm so happy to be here. So, and hi everyone, I'm talking from very far east, now in Japan, 11:18. So today's my talk is about the surgical neurology of cervical myelopathy. And the surgical the surgical neurology is the word originally coined by me, which means clinical significant or practical diagnostic neurology for spine surgeons. The majority of audience may be spine surgeon, and one side of our body is ortho, and another half is neuro. And we stand on the platform of information of neurology. The preoperative correct diagnosis is one of the keys to obtain good results, and especially in the cervical spine field. Now, let's come back to our medical students' days. The level diagnostic study of cervical myelopathy has been pursued very actively in Japan because we had a lot of myelopathy cases with narrow spinal canal and OPLL. Speaking on motor neuron dysfunction, we should know the basic neurology about first and second motor neuron of the spinal cord. Dysfunction of first motor neuron in white matter give rise to hyperactivity of the extremities and spastic paresis or paralysis at caudal level of the pathology. And second motor neuron dysfunction in the gray matter cause fasciculation, weakness, or atrophy, decreased muscle stretch reflex or of the related muscles at the pathologic level. We should distinguish the long tract signs from segmental spinal cord signs. Talking about motor neuron, a long tract signs reflect the dysfunction of the first motor neuron in white matter. And segmental spinal cord sign means the disturbance of the second motor neuron. And second motor neuron consists of anterior horn cells in the gray matter and its axonal rootlets and nerve root. This slide shows the anatomical correlation between spinal cord and nerve root. Notice the oblique pathway of the root. For example, the cord compression at this level, if the compression factor is a disc hernia locates in the central part, C6 spinal cord segment is disturbed. When the bony spur develops laterally, the C5 root is compressed. The nerve compression factors at the same disc level can give rise to different neurological abnormalities, C6 or C5. Hoppenfield Neurological Index is very popular in the world, but this is one of the causes of misunderstanding on level diagnosis in cervical myelopathy. These findings indicate the correlation between involved disc level and radicular syndrome, not cord dysfunction. We should not confuse the cervical myelopathy with radiculopathy using this index. As for the level diagnosis, we should not confuse myelopathy with radiculopathy. Kokubun reported a variable index of level diagnosis in cervical myelopathy by means of intensive investigation of pre- and post-operative neurological findings in cases with a single compression level. He called attention to the segmental spinal cord sign and found this useful index. We repeated his work for about 35 years and we recognize its clinical diagnostic value. In this talk, I adopt the motor index alone because the results of sensation testing were occasionally bizarre and its reliability and reproducibility seems to be doubtful. According to the Kokubun's myelopathy index, C5, 6, 7 segment seems to be located like this. This basic recognition is quite useful for understanding of clinical signs and symptoms. For example, in this case, slow grasp and release of the hand and hyperactive patellar tendon reflex are indicative of cervical myelopathy. Biceps reflex may come from this. Biceps reflex was diminished and the triceps reflex was hyperactive. These findings may come from this level. In addition, the activity of deltoid reflex decreased, maybe because of this level lesion. These hypoactivities of reflex are a segmental spinal cord sign in each level, and these increased activities of reflex are a long tract sign. The reflexes plays a significant role in clinical neurological exam because changes in their intensity and character may be among the earliest and most delicate indications of disturbance in nervous function. In addition, most objective finding. Hammer tapping stretches the the muscle, and electrical signal transmitted to the spinal cord and comes back to the muscle via reflex arc. And finally, the muscle contraction is observed and we can find the activity of muscles. Tendon is usually selected as a tapping point because of best portion to stretch muscles effectively. So we should not use the terms tendon jerk, deep tendon reflex or so. The muscle switch reflex is the physiologically correct term. So I would like to explain our testing maneuver of deltoid and triceps reflex briefly, because they are the keys of C5 and C7 spinal cord segment signs. In deltoid reflex testing, tapping over the origin of the deltoid is followed by the contraction of the muscles with a resulting abduction of the upper arm. In textbooks, the tapping over the incision of the deltoid at the lateral aspects of the humerus is recommended to stimulate the deltoid. According to our experience, however, the deltoid reflex is not elicited effectively by this maneuver, perhaps because the muscle bellies of biceps and triceps brachii interfere with the hammer stimulation, especially in obese patients. I recommend examining the triceps reflex with the patient in the prone position. In this position, the patient's forearm is easily hung limply with maximum relaxation, and the triceps reflex is elicited effectively with easy observation of the response. Because of the same reason, so-called Achilles tendon reflex, physiologically correct term is triceps striae reflex, is to be examined like this. Talking about Wartenberg, Fachmans, and Tramners, they are recognized as pathologic reflex in some textbooks, but this is wrong. They are the muscle stretch reflex of finger flexors, innervated by C7 to T1 cord segments. So when this reflex is positive, means the activity of finger flexors increased. Neurophysiologically speaking, positive or negative are not correct expression because these are muscle stretch reflex, not pathologic reflex. These reflexes are the keys to know the neurological abnormality at cervicothoracic junction. Clinical significant neurological findings are uncertain at the high cervical level. The jaw reflex gives us an information of the brainstem lesion, and the level of the myelopathy caused by the lesion caudal to the C5 spinal cord segment can be evaluated by conventional neurological testing of the extremities. High cervical lesions, however, are difficult to localize because of the difficulties involved in testing them. Furthermore, the various patterns of neurological abnormalities may be found with high cervical lesions. For these regions, uncertain or false localization may occur with lesions at high cervical level. Motivated by a special interest in this issue, I have made an effort to find special long-tract neurological abnormality associated with high cervical level. At first, I focused on the accessory nerve. Because this nerve filament originates in a wide range of high cervical region, and I noticed that the trapezius is ideal muscle innervated by this nerve for its reflex taking. Then I discovered scapular-humeral reflex chemism. The trapezius is too big and the complicated insertion of scapula. Only upper portion of the trapezius is examined. The scapular motion is the key to observe. The SHL is elicited by tapping at the tip of the spine of the scapula and acromion in the caudal direction. Only when elevation of the scapula and or abduction of the humerus are clearly defined after tapping at these points is SHL classified as hyperactive. Scapular elevation and humerus abduction of this testing are regarded as hyperactivity of trapezius, levator, scapular, and deltoid, respectively. Hyperactive scapular-humeral reflex case. You can see the scapular elevation and the humerus abduction. Same case, activity of deltoid are increased. A localization of reflex center of SHL chemism is shown here. Let's move on to the myelopathy hand. Slow grasp and release of the hand is one of the representative one. Release phase is always slower than grasp phase. In the more developed stage, you can see the trick motion, trick extension of the MP joint by wrist flexion. MP joint becomes not to be extended. Otherwise, IP joint can be extended. This is a representative myelopathy hand. In this case, right hand is okay, no problem. And grasp and release testing in left hand, IP joint could not be extended, but MP joint were extended. Yes, this is not myelopathy hand. This patient suffered from motor neuron disease. 3 years after this examination, he died of respiratory failure. This slide shows a level diagnostic decision tree regarding muscle stretch reflex. Hoffman and Traminor are the keys to detect the cervical-thoracic junction level, and the scapular-humeral reflex and deltoid reflex are the keys to find out high cervical region. The precise neurological examination by yourself is quite important as a spine surgeon, and don't overlook both lesions at craniovertebral junction and cervical-thoracic junction. Thank you for your attention.
Thank you, Dr. Takashika. It was really a wonderful overview of the surgical neurology. And I believe this will make us certainly better surgeons and better results. I'll take the opportunity to launch your questions that we can submit to vote. Do you want to read them, Dr. Takashika?
Yeah.
So which
yes.
of the following is correct? I have the questions here on the screen.
Okay.
So which
everyone
of the following
now?
Yeah, everybody's seeing now, yeah. So when the patient has hyperactive tricep reflex with diminished absent biceps reflex, we should suspect C5-6 disc lesion. Neurophysiologically speaking, positive or negative is the correct way for recording the result of Wartenberg reflex test. Another answer, hyperactive scapulohumeral reflex and deltoid reflex are one of the keys to notice high cervical myelopathy. It is not difficult to determine whether the muscle atrophy of upper extremity in myelopathic patients is derived from anterior horn cell dysfunction or nerve root. And so we have a second set of questions. Mm-hmm. So don't many people dare to vote. I'm gonna close here I'm gonna share the results. Can you see the results?
So
we can see the results, yeah. There is a okay. Can you comment briefly on your
yeah.
We can see the at least in my screen. We should probably stop sharing. Okay.
So everyone votes. The first is yes.
Yeah. So which one is the
No.
correct for the first question?
Third one.
The third one.
Yes,
Okay.
third one is correct.
And for the
So,
second setting?
Yes, the first one, the biceps is innervated mainly by C6, and triceps is innervated by C7, and hypoactivity of biceps and hyperactivity of triceps indicates C6 spinal cord segment dysfunction. And C6 cord segment likely locates in C4-5 disc areas, as I showed in the lecture. And
Very good.
why? Yes, and why? It's okay.
Yes, yes.
Time is very short.
Yeah. Okay, and the second question?
The second one. So the second question means that the Walton-Wilk reflex.
Yes.
Walton-Wilk reflex and Hoffman and Tremner is not some pathological reflex. So pathological reflex should be recorded as the positive and negative, but muscle switch reflex of the flexors should not be recorded as plus or minus. This is my answer.
Okay, thank you.
Mm-hmm.
Is then Rio around then?
Yes. Yeah.
And I have a question from a participant on YouTube. It's Dr. Kitumba from Angola. He's watching us from there. He raises a question: how could you, in the clinical setting, differentiate a cervical radiculopathy from a carpal syndrome? Very briefly.
From what syndrome?
Tunnel carpal syndrome. Rick.
Oh, carpal tunnel syndrome.
Yeah.
So on physical exam with a carpal tunnel, you'll often have deficits with a compressive phalanx where you compress and bend with the tenelles over the carpal tunnel. But sometimes it's not easy. If you do a Sperling's and they have symptoms, it's clearly coming from the neck. And if you have numbness that comes proximally, it can come from the cervical spine as opposed to this. But with severe carpal tunnel syndrome, patients will say, I have pain that comes from the neck all the way down into the hand. And if you tap on the carpal tunnel and it elicits the pain, you know it's a carpal tunnel syndrome. And finally, you can get EMG nerve conduction studies, but EMG is when they say there's nothing wrong, they have a false negative rate of 20%. So you have to understand that EMGs are not perfect. So it's a combination of exam history as well as EMG nerve conduction studies.
Okay, thank you, Dan. So you said EMGs are not perfect. So this sends us to the next talk. Is Professor Dileli from Ege, Izmir, Turkey. He's the chairman of the World WFNS Spine Committee, first and founding president of the spine section of Turkish Neurosurgical Society. He was president of Turkish Neurosurgical Society of the World Spine Column, and Asia Pacific Cervical Spine Society. So he's elaborating on the topic if image takes it all or diagnostic electrophysiology is still important. Please, Mehmet, go ahead.
Thank you, Oscar. It's a great honor to be with you all, very distinguished speakers. I will try to share my screen.
Yeah, perfect.
Yeah, this is a very confusing subject. Actually, do we have to rely on the electrophysiology? During our consensus meeting on cervical spondylotic myelopathy, we have done a PubMed search. There was 919 hits with cervical myelopathy and evoked potential, and then EMG and electrophysiology. We had got the opportunity to publish our results in the Neurospine Journal in 2019. We had first questions about the subject, which electrophysiology tests are suggested to be used. There are many actually: SEP, MEP, spinal cord evoked potentials, EMG cutaneous silent period, and contact heat evoke potentials. Are they useful in differential diagnosis of CSM? There are some studies that cervical root stimulation will allow more clear distinction between motor neuropathy and demyelinating polyneuropathy, and MEPs with triple stimulation may be more useful in ALS diagnosis and something like that. But all these studies are stressing that in the mild forms of those diseases, it's impossible to differentiate it. I mean, you can not even differentiate ALS or polyneuropathy from a cervical radiculopathy or CSM in the early phases. We need to make some special tests. In the routine tests, it is quite difficult. Something like root stimulation, triple stimulation, MAP, and some other forms of electrophysiologic tests are necessary, which is not done routinely. If you look at the prediction of outcomes of CSM, there are old studies telling us that SEP are very useful, but very recent studies are more critical. MEP, central motor conduction times, there are some old studies useful, but not useful, and useful only in mild CSM cases. There is still some confusion. We can comment that MAP and SEP are valuable tests to predict outcomes, but there is no good evidence that they are more valuable than clinical parameters, or they are not more valuable than radiologic parameters. So we ask the question, are those tests better than MR changes in prediction of outcome of CSM? In one study from 2017, the median water fraction in 3 Tesla MR is correlating well with SEP latencies. So this is good that it's almost like a similar, given the similar prediction values. In another study from 2015, electrophysiology is better than CSM, they have found it. But in another study, if you look at the diffusion tensor imaging, DTI, MRI prediction is better than electrophysiologic tests, 2014. In pre-symptomatic CSM evaluation, there is a unique result, actually. If positive electrophysiology, time to CSM development are expected to be less than 12 months. However, in MRI hyperintensity, it is expected to be more than 12 months. So then early changes can be predicted by electrophysiology, but later changes can be predicted by MRI hyperintensity. What about the monitoring of surgeries, of CSM surgeries with electrophysiologic tests? Shall we rely on them, and then shall we use them in the routine setup? There are mainly 3 types of MEPs, motor evoke potentials. One is the cranial electrical stimulation recording from intradiscal electrodes, which has disappeared nowadays. It was in 1995. They were by Japanese electrophysiologists. But then, especially, again, Japanese have used that spinal cord evoke potentials, stimulation or recording from spinal cord epidural electrodes, and cranial electric stimulation and recording from muscles. There are mainly 3 types. And this study have found that it is from 2005, spinal cord evoked potentials can localize the lesion in correlation with functional outcomes. It is better than myogenic motor evoked potentials. However, if you look at the retrospective reviews of large series, 720 patients, it's from 2012, this study has found whether they are using anterior posterior or combined approaches. Only in 3 patients they had some neurologic deficits postoperatively, and they decided monitoring in CSM is unnecessary. It's not necessary. In another study, MEP is more sensitive than SEP for detecting myelopathy, which correlated well with abdominal MR images. In one study from 2017, with 131 patients, SEP monitoring is not useful, and MEP monitoring is also not useful for lower extremity power, but it's useful for detecting C5 nerve palsy. Again, 2017 study with very large number of cases with ACDF, and they found that monitoring in ACDF cases is not necessary. It does not prevent the rate of postoperative neurologic complications, and the routine use is not necessary, they say. In one study from 2018, improvement of MAPS during surgery may reflect better outcomes of motor function. And in this study, MAPS by cortical stimulation and recording from deltoid muscles is valuable in detecting C5 nerve palsy. Again, C5 nerve palsy monitoring is good with MAPS or EMG. So, prediction of intraoperative neurologic worsening. MAPS are sensitive. MAPS had unnecessary alerts in 18% of patients who did not have any postoperative deficits. Myogenic MAP recordings from the deltoid and biceps are more sensitive than any other electrophysiologic tests. So, we can consider monitoring as a sensitive technique to diagnose potential neurologic injury during surgery. However, intraoperative worsening is not specific, and it does not show clinical worsening in every case. So, in conclusion, if you look at our questions, which electrophysiologic tests are suggested to be used in CSM diagnosis or in the preoperative evaluation, MAPS are better than spinal cord evoked potentials than SEP, EMG, and CSF. Are electrophysiologic tests useful in differential diagnosis? Simply no. Specific tests are necessary, and mild forms of ALS and polyneuropathy may not be differentiated easily. Are electrophysiologic tests useful in prediction of outcomes? No. MAP and SEP valuable to predict outcomes of CSM, but no evidence that they are more valuable than clinical parameters. Are those tests better than MR changes? There is some consensus in the literature, but it is level 3. And if you look at the DTI, diffusion tensor imaging, it is better than MEP. Are electrophysiologic tests useful in monitoring of surgeries for CSM? No for lower extremity power, but yes for C5 root palsy. And EMG and MAP monitoring may be useful to decrease C5 root palsy. Thank you for your attention and listening to me.
Thank you, Mehmet. It was really insightful lecture. And while I'm preparing here yes, please, can you unshare the screen? While I'm preparing here the question, so can you tell me from the diagnostic side, which are the situations that you use electrophysiology test in daily practice?
Yes, intraoperative usage is more reliable than diagnostic usage. I don't actually, if I'm very much concerned about the diagnosis, for differential diagnosis, yes, I ask for electrophysiology before surgery. But if I'm not, I don't do it. Okay.
So Mehmet, I'm going to launch the questions related to your topic. We can see it in the screen. Do you want to read them for us? Or?
Yes. First question is that
for differential diagnosis of cervical myelopathy.
Yes.
Which statement below is correct?
Cervical spondylotic myelopathy, which statement below is correct? Routine electrophysiology, needle EMG and nerve conduction velocity is useful in distinction of ALS, polyneuropathy and radiculopathy in all stages. B, routine electrophysiology is not useful in distinction of ALS, polyneuropathy and radiculopathy in early cases. C, ALS can easily be differentiated from CSM in early phase. D, radicular lesions and polyneuropathy can easily be differentiated in all stages. E, specific electrophysiologic tests are not necessary in distinction of ALS and others.
Okay, second question. Which one of the tests below is more sensitive for spine tract damage?
Yes, which test below is more sensitive? A is somatosensory evoked potentials, B is spinal cord evoked potentials, C motor evoked potentials, D MRI diffusion tensor imaging, and E MRI T2 hyperintensity.
And the third question, are electrophysiological tests useful in monitoring of surgery for cervical myelopathy?
Yes. A, yes, it is useful both for long track and segmental monitoring. B, yes, it is useful for C5 root motor function, but not for lower extremity power. C, yes, it is useful for lower extremity power, but not for C5 root motor function. D, yes, it is useful for anterior cord function. No, it's not useful at all.
Thank you, Mehmet. So I'm going to close and going to share the results.
Okay.
Can you see the results being?
Yes.
Okay, so let's say for question one, people think that the second one is the correct one. What's your answer?
Yes, B is the answer. The correct.
Perfect.
Yeah, second.
Perfect. For the second question, people split among B, C, and D.
Yeah.
Which one is the correct?
D is correct. Yeah, MRI diffusion tensor imaging, DTI.
Exactly.
Is for the long track, spinal tract damage, it's better.
For the third question, majority think B is correct.
For the third, yes, B is correct. That's fine.
Okay. Okay. Thank you, Mehmet.
I thank you, really.
Thank you so much. Now I call Professor Nazira Asnan. I have to tell that CSRS Europe welcomes the first joint collaboration with International Spinal Cord Society. And we are honored to have Dr. Asnan with us. She's member of Educational Committee of International Spinal Cord Society, Professor and Director of Department of Rehabilitation Medicine, University of Malaysia, Kuala Lumpur. and we are very happy to have her here to talk us on autonomic dysreflexia.
Hello, thank you, Oscar. I'm very happy to be here tonight. I'll be talking on autonomic dysreflexia, which is a medical emergency in persons with spinal cord injury. I'm a rehabilitation physician and I'm based in Kuala Lumpur, Malaysia. I start by sharing with you a case report that my team published a couple of years ago on complication resulting from severe autonomic dysreflexia, which results in intracerebral hemorrhage. And this was a patient who was 33 years old, who had problems with bladder management and required a suprapubic catheter placement surgery. And so it's a very, very simple surgery. However, the surgery was uneventful, but however, within a day after surgery, he developed problems with hematuria, having blood clots in the catheter. And as a result of that, he had blockages of the computer, and this resulted in autonomic dysreflexia. The autonomic dysreflexia was very intractable, and even with medications that was given to him, he ended up with an intracranial hemorrhage. So as you can see on the case report, there's a CT scan of the brain, which shows intraparenchymal bleed over the frontoparietal region. And this resulted in someone who was presented with paraplegia, and he became a triplegic after suffering from intracranial hemorrhage. And he had undergone rehab, and he has recovered somewhat, but he is still having triplegia as a result of severe autonomic dysreflexia. So as you can see, it can result in grave consequences. It's potentially life-threatening. It has a mortality rate of 22% and mostly due to CNS complications. Systematic review by Krusakov and Wan in 2014 reported that the majority of complications from autonomic dysreflexia are related to CNS complications such as seizures and stroke. And a recent report stated that an autonomic dysreflexia increases a risk of stroke by 300 to 400%. And more importantly, someone who's got a spinal cord injury with such severe disability has now is at risk of worsening impairment and disability. So the definition of spinal cord injury, according to the international standards, is an insult to the spinal cord resulting in change in normal sensory, motor, and autonomic functions. And so it is not surprising that we are seeing problems with autonomic dysfunction in people with spinal cord injury. So what is autonomic dysreflexia? It's a condition unique to persons with spinal cord injury. It's usually in spinal cord injury above T6 level, and 20 to 70% of people with above T6 level will experience autonomic dysreflexia. It's 3 times more prevalent in complete spinal cord injury, and it's defined by an acute episode of systolic blood pressure, which is 25 millimeter mercury above patient's normal blood pressure. It's usually secondary to a reversible and treatable cause. So most of the autonomic dysreflexia are self-limiting. The higher the level of spinal cord injury, the greater the risk. And what's interesting is it develops 1 month to 1 year after injury, but we do see cases even in the first few days or weeks after injury. Therefore, it can occur when the patient is still in acute care or spinal unit. So if we have a patient who's T6 and above, there must be a high index of suspicion if we get someone with high blood pressures and symptoms of headaches and other related symptoms, which I'll come to in a bit. So how does it occur? So a person must have intact nerve roots. They must have intact spinal cord above and below the injury. So this spinal cord is disconnected. They must have intact sympathetic response below the level of the lesion, and an intact parasympathetic response above the level of the lesion. So what happens in autonomic dyslexia? So a person can have a painful or even just an unpleasant stimulus below the level of injury, and this trigger a widespread reflex activity of the sympathetic nervous system below the level of injury. And this sympathetic response, which is from T6 to L2, becomes uncontrolled because the spinal cord is now isolated from the normal regulation by vasomotor centers in the brainstem. So when this happens, with the widespread sympathetic response, there are release of substances such as noradrenaline, which causes severe vasoconstriction with pale skin, piloerection, and of course hypertension. So when this rise of blood pressure is sensed by the baroreceptors in the carotid and aortic baroreceptors, so what it tries to do is, number one, it increases the vagal parasympathetic drive to the heart. So, and this results in relative bradycardia. So that's why in autonomic dysreflexia, you get high blood pressures, but with bradycardia. And at the same time, what it does also is it also sends afferent responses to the brainstem, which then attempts to lower the blood pressure through vasodilatation. So what happens with this? So with vasodilatation, the patient gets pounding headache, the patient will get flushing, sweating, blurred vision, as well as nasal congestion. So what autonomic dysreflexia actually is actually a product of dysregulation of the autonomic system, which leads to an uncoordinated response to a noxious stimuli below the level of injury. So what are the causes of autonomic dysreflexia? So I've arranged it from the most common to the least common. So the most common, the first thing first would be urinary complications, usually bladder distension, a blocked catheter, a kidney stone, or even problems with catheterization or the catheterization itself. The other common things is urologic instrumentation, as what happened with my with the patient that I presented, and also urinary tract infection. If we can rule out bladder complications, the next one is bowel complication, usually due to bowel distension, fecal infection, and constipation. Following that will be skin, musculoskeletal, reproductive, and other problems. It's best remembered by the 6 Bs: the bladder, bowel, boils and blisters, which refers to skin damage, which involve pressure injuries, burns, ingrown toenails, other trauma to the skin, including tight clothing. The fourth one is bones, fractures, dislocation, babies, anything that's associated with babies, menstruation, sexual intercourse, pregnancy, labor, breastfeeding. All this can trigger an autonomic dysreflexia. And back passage, such as hemorrhoid, fissures, and always check the back when you can't find any cause, any trigger to the autonomic dysreflexia. And it has been reported that medical and labor can be complicated in patients with repeated history of autonomic dysreflexia. So, as I mentioned, autonomic dysreflexia can happen even days after the injury. So what are the possible triggers that can happen in the acute settings? As I mentioned just now, distended bladder, and we have to look for kinks, positional problems of the catheters, and even a full urinary bag can trigger an autonomic dysreflexia. The others, as I mentioned, constipation, pressure injuries, and what we have to bear in mind are unresolved acute injuries. Patient is still recovering. Patient could be having fractures other than a spinal cord injury, and these fractures are still unresolved, and other injuries below the level of lesion, which is causing pain and irritation to the patient. And the other one is post-op pain, patients not getting inadequate analgesia. What's more common are the interventions from the medical, nursing, or rehab, such as putting on the lower limb pneumatic pump, which goes intermittent pumping to the lower limb. This can cause irritation and pain, and this can result in autonomic dysreflexia. Anti-embolic stockings, which are too tight, positioning which is not favorable to the patient. Some physical therapy interventions, including exercises, stretching exercises, can trigger an autonomic dyslexia. Application of autosys, procedures that are being done for the patient, this can trigger an autonomic dyslexia as well. What we have to bear in mind is things like IV cannula lines shouldn't be inserted in the lower limbs, because patients will not be able to feel, and you can get inflammation, you can get recited cannulas and lines, and this can cause pain and autonomic dyslexia in patients. So how do we evaluate our patients? Through history and physical examination as usual. So AD can present in varying intensity from mild to severe life-threatening medical emergency. They present with headache, flushing, profuse sweating, and anxiety is very typical, as what you see up in the cartoon figure up there. So patients will have pale skin below the level of lesion, piloerection below the level of lesion. Some will complain of blurred vision, nasal congestion, and will probably have chills without fever. History of previous AD points to a possible autonomic dyslexia when presented, and other relevant histories such as urinary problems. As mentioned just now, most of the AD causes are due to overdistension of bladder. Other medical history is very important, such as existing hypertension or coronary artery disease, because this can impact the autonomic dyslexia itself, as well as complications from autonomic dyslexia. Physical examination to look for level of completeness of injury that can point to the autonomic dyslexia and the suspicion of autonomic dyslexia. BP, high systolic blood pressure plus minus bradycardia. We have to be aware of low baseline blood pressure in people with spinal cord injury, especially in those in high spinal cord injury, especially in the tetraplegics. The baseline blood pressure can be anything between 80 to 90 millimeter mercury in the systolic blood pressure, and a normal blood pressure in a non-spinal cord injury patient may indeed be a raised blood pressure in a spinal cord injured patient. So we don't really need any investigations. Diagnosis is made based on clinical findings and a high index of suspicion. We must also remember that clinical interpretation can be very tricky, because you can also see the patient presenting with other symptoms and signs, because severe hypertension can lead to hypertensive crisis, and patients might be presenting with signs and symptoms of pulmonary edema, left ventricular dysfunction, retinal detachment, and as shared earlier, intracranial hemorrhage. And patients, I've mentioned that patient can present with bradycardia, and some can also present with cardiac arrest. Some patients can present with tachycardia instead of bradycardia, and this can occur alongside with cardiac arrhythmia or atrial fibrillation or flutter. If the patient has existing coronary artery disease, an AD episode may cause myocardial infarction, and as mentioned, high blood pressure can cause intracranial hemorrhage when combined with cerebral vasodilatation due to the parasympathetic response. How do we manage autonomic dyslexia? The goal is to remove the cause, alleviate symptoms, and avoid complications associated with uncontrolled hypertension. And we do acute management. In some patients with persistent AD, we have to do management for persistent autonomic dyslexia, and also we have to consider prophylaxis in some patients who are undergoing some procedures. So in the initial step, when we see a patient with autonomic dyslexia, we ask whether they suspect of a cause. Quickly elevate the patient's head and lower the legs. This is very important because you want to induce pulling of blood in the lower limbs, as well as reduce venous return, and you can balance the high blood pressure. Quickly loosen constrictive clothing. If the patient is wearing abdominal binder, compression stockings, autosys, remove all that. And blood pressure must be removed must be measured every 2 to 5 minutes. And we recommend a manual blood pressure because is used because things automatic blood pressure measurements such as Dynamap and all that may take a longer time to detect the blood pressure, or sometimes the blood pressure may be too low to be detected through the automatic blood pressure devices. And it's very important to continue monitoring because the blood pressure will continue to rise very rapidly until it's successfully treated by removing the stimulus. So we have to rule out each cause by working from the bottom up. Start with the most common cause first, which is bladder. So check the bladder. If no catheter, to catheterize. Always use a topical anesthetic such as a lignocaine gel. But it's important to empty the bladder slowly by lifting the draining end, because if it's done too quickly, it can cause spasms and further raise the blood pressure, or it can also cause sudden hypotension. If a catheter is already in place, we look for kinks and also the patency of the catheter, and we may even have to reinsert a new catheter. If the bladder is not the problem, check for bowel problems. And if there is stool in the rectum, we have to remove it manually. Always evacuate using topical anesthetic agent and do a digital stimulation. And most of the time, you do not need pharmacological intervention. If we don't find any bladder bowel cause, then we commence systematic survey of the patient for other causes of autonomic dysreflexia, such as any skin problems, any ingrown toenails, anything that's causing pain to the patient. And if the blood pressure is persistently more than 100 millimeter mercury systolic blood pressure, and we cannot find the trigger, pharmacologic management should be initiated. The first line that is recommended is glyceryl trinitrate, usually a GTN spray or sublingual tablet, or transdermal patch. The good thing about transdermal patch, you can remove it as soon as the blood pressure comes down. However, this is just based on level 5 evidence, but this is the recommended guideline from the Royal College of Physicians and the British Society of Rehabilitation Medicine. The alternative is a sublingual captopril 25 mg tablet that's put under the tongue, and this has been shown that it can lower blood pressure within 15 minutes of administration. However, nifedipine remains a drug of choice for many, despite concerns in non-spinal cord injury population, and many practitioners still find it very, very useful because it doesn't cause problems with headaches. And in refractory cases, parenteral drugs can be used, and patients must be admitted and managed in the ICU for this. Special considerations with regards to management are those undergoing medical or surgical procedures with general or regional anesthesia may be used. And for regional anesthesia in the form of spinal anesthetic, this has got an advantage because then it can block the reflex out and prevent AD. And epidural catheter can also be considered because it can be topped up. In women with labor, epidural anesthesia is the method of choice. And for cesarean delivery or instrumental assisted delivery, such as vacuum assisted delivery, a spinal or a epidural may be used. So once the AD is resolved, patients need to be monitored until the BP restored to baseline. And once stabilized, the doctor and the team will need to review the precipitating cause with patient and caregiver. And we must be aware that some hyperactivity of the sympathetic nervous system may be experienced over the next few days. In the patient that I presented to you before, it went on for about 10 to 11 days. And this is what is called status dysreflexicus. And because of this, patients should be monitored for any exacerbation or reappearance of symptoms. So for those who have prolonged and recurrent autonomic dysreflexia, prazosin can be given as a regular medication to maintain the blood pressure. And as mentioned just now, prophylactic management can be given for those going for labor, those going for medical surgical procedures, and also when doing bladder and bowel care. Individuals and their caregivers must be well educated to recognize and treat autonomic dysreflexia and seek emergency treatment. They must be aware of common potential precipitating causes and importance of preventive measures. They should be supplied with an AD kit, a blood pressure kit at home so that they can measure their blood pressure. They must have an AD card which tells them what to do, and this AD card can be taken with them to the GP or to the emergency departments. And we must empower people with spinal cord injury and their family members with regards to autonomic dyslexia, and also educating healthcare providers with regards to AD, because AD is often not recognized by healthcare providers. Specialized nursing care is very important. Awareness and understanding of what it is, prevention and precipitating factors need to be aware, and nurses must know how to identify AD early and institute urgent intervention. And healthcare workers, or rather people working with spinal cord injury, must take measures to increase the level of awareness on autonomic dyslexia by educating all other healthcare providers. In conclusion, autonomic dyslexia is a well-known consequence of spinal cord injury among individuals with thoracic and cervical, high thoracic and cervical injuries. It's a life-threatening condition. It can result in a variety of significant complications in medical personnel, caregivers, and individuals with spinal cord injury should be educated with regards to the importance of timely diagnosis and management of autonomic dyslexia. Complications can result in worsening disability, impacting functioning, activity, and participation, and complications can result in death. And with that, I say thank you.
Thank you, Nazira. It was a very complete overview of this neglected syndrome. As you said, we did a high suspicion index for diagnosis. So I'm going to go right to your question, which I'm starting now. You want to read them, please?
Okay, so I've got two questions here. Number one is autonomic dyslexia. One is due to the inability of the strong sensory stimulus below the level of the lesion to reach the spinal cord. Two is more prevalent in those with complete injuries. Three is unlikely if a patient with AISB C5 presents with headache and a systolic blood pressure measurement of 122 millimeter mercury. And D, autonomic dyslexia resulting from a blocked urinary catheter can be managed. Oh, it's not full here. Can be.
I'm sorry.
Yeah, this is not complete.
Okay, I'm sorry.
So resulting from I think the question was autonomic dyslexia resulting from a blocked urinary catheter can be managed by applying compression on the bladder.
Okay.
So
and the second question?
The second question is all of the following unknown complications of autonomic dyslexia except for seizures, cardiac arrhythmias, intracerebral hemorrhage, intra-abdominal hemorrhage. From
okay, so I'm gonna close and share the results.
Yeah.
So for the first question, half of the people split in answer 1 and 2. So right. What's the correct one?
Okay, the correct one is B. It's more prevalent in those with complete injuries. As mentioned in my presentation just now, for autonomic dyslexia to happen, you must have an intact spinal cord above the lesion, below the lesion. Yeah. You must have an intact sympathetic system below the lesion and intact parasympathetic system above the lesion.
And for the second question, people think it's not common intra-abdominal hemorrhage.
That's correct. Yeah.
That's the correct one, right? Okay, very good. So let's move forward now. Thank you, Nazira. We go now for the surgical part of the webinar, and I would like to call my good friend from many years now, Professor Saleh Baissa. He's Professor and Head of Neurosurgery in King Abdulaziz University in Jeddah, Saudi Arabia, and he's going to present us on the issue of autologous bone graft. Is it out of fashion in cervical spine surgery? And what are the issues around this question? Please go ahead.
Thank you very much, Dr. Alves. This is a very nice webinar so far, and I'm happy to participate in it. And I thank you for giving me this title. I haven't read a long time ago about this subject. I think it's very important to go over it again. You know, the cervical spine surgery, especially fusion, is not something new. And actually, it's one of the commonest surgery that we do. And since the introduction in the 50s by Smith Robinson and Cloward, there are many modifications of the technique, although the technique is different between the two, but they share something, which is the bone graft and fusion, which is one important outcome in this operation. Also, not only for fusion, just to also maintain the foramina and the height and lordosis. Now, in spine surgery, especially for the cervical, we use 3 sites or maybe 2 of these in our practice to obtain cancellous or cortical or corticocancellous. Electrophysiology is the most popular since you're doing cervical spine anteriorly and in a supine position, and it can be done simply for single or even multiple ACDFs. And sometimes for corpectomy up to 2 levels, you can get up to 10 centimeter long electrophysiology for fusion. The second option will be fibula, and fibula could be vascularized or non-vascularized. Vascularized option is very good for patients who's had radiation locally to the spine, or you're doing this for tumor. Also, if you're doing this for a long segment corpectomy, this will be ideal. The third option, ribs, which is usually common in thoracic spine, where the incision usually 1 incision, and you can get the ribs from that area. Bone grafting for spine surgery is not a new topic. This is a good review by Dr. Vaccaro, and Dr. Wang is one of the authors of this nice paper. It's outlined that the autograft fundamental factors in osteogenicity, osteoconductivity, and osteoinductivity as a gold standard material for fusion. However, there are acceptable alternatives like allograft, which could be fresh frozen, or freeze dried, which is not usually readily available in many countries. And the one we use for the cervical spine, usually the freeze dried, because it has less immune response or reaction as opposed to the fresh and fresh frozen. The other allograft type, which is the decalcified cortical bone of allograft, it's called the DBM. Other growth factors, especially BMB, are important acceptable alternative, and synthetic like ceramics, like hydroxyapatite and tricalcium phosphate. These can be done either one or in combination with others, and sometimes can be supplemented with bone marrow aspiration technique to get more cells to improve the fusion. In the market, there are many spacers. If you are doing discectomy, you can put a spacer. What's in the spacer, which is the important, either you're going to go with the autologous bone, or you will go with other alternatives. These spacers present in a various types of sizes and with anchoring or without anchoring, and some of them they are useful for corpectomy for several levels. Now, allograft, again, gold standard. This is an important material you get from the bone. You get cells, growth factors, matrices, and this is from the same patient, so there is no risk of transmission of disease. And in one of the literature, you know, they caught like 1 in 1 million transmission of HIV in patient with allograft. For some reason, this technique is being less and less practiced by spine surgeon. I remember the last one, I've done it more than 10 years, and even my resident, they don't know how to do the electrophysiology graft. On the other side, every week in next door, you get a craniofacial or facial-maxillary surgeon. They're doing this almost on a weekly basis. So it's something that I think we did not keep in our practice. The technique is not the time for it to describe it here, but this is a good paper by Ibrahim and his colleagues, describe the techniques of obtaining cancellous, cortical cancellous, or even tricortical bone graft. And he highlight at the end the important complications, especially donor site pain and cosmetic deformity, nerve injury. It can happen. The commonest one is the lateral hemocutaneous nerve of the thigh. Sometimes it has an apparent path where it goes over the iliac crest, not under the ligament. Rare complication like fracture of the ilium due to avulsion. So you always keep 3 centimeter and more taking the iliac crest graft from the anterior superior iliac spine. Hematoma, it's not very rare. The hernia and infection, these are very, very rare complication. In this paper by Banwart, he did a study on 180 patients in the 80s for 64 months, and in his practice, although this operation done by a single surgeon, they have a major complication up to 10%, including nerve injury, hematoma, seroma, and cosmesis. The minor complication, including pain, is up to 39%, and they have mixed anterior and posterior. So 39% was the number I caught from his paper for the anterior complication. There are many other studies came, and always they stood beside that study, and with a very variable range of complication between 2.5% up to 49%, which is a very high complication number for a donor site pain from this surgery. If you talk about only the anterior iliac crest bone graft harvesting, there are a few studies that has some details on this one. This study showed there is around up to 20% incidence of complication the graft harvesting. Some of them require additional surgery or increased hospitalization. Up to 20% of patients in other studies showed there is persistent pain up to 2 years, and up to 9% require chronic analgesia from the donor site complication. Up to 3% in one of the studies showed there is persistent pain, which can be severe, and up to 6% they have suffered local wound complication, and up to 3% require additional surgery for graft complication. For the fibular graft, the story is not different. The complication is still there. And in this one study by Nasser, almost 10 years ago, he had a retrospective analysis of 133 patients underwent anterior cervical corbectomy and had a follow-up up to 8 years. The incisional pain in less than 3 months was up to 53%. And after 3 months, the percentage dropped down, but still to 15%. 2 patients of that study had neuroma, and 15 patients had wound infection. 5 patients, they have tibial fractures, required surgery, and 2 patients had an ankle instability, which is a significant long-term morbidity in those patients. And this is their table and the picture showing the operation they had done for one of the patients. And you can see the long-term complication, it goes less and less. In the first 6 months, you have 15%. After at 12 months, you have 7% of local pain, and then after 1 year, you get 5%. And then, but the problem remained in the long-term complication from the fracture or ankle disability. McLean, he came with previous others trying to go with the minimal invasive techniques in harvesting the iliac crest bone through a trephine, and he did this in 68 patients who underwent anterior cervical discectomy and fusion over 6 years. He used the specific trephine of 3.5 millimeter, and his outcome was really good, that there's no infection, there's no local complications. The pain was mild for perioperative in one patient, and even postoperative in one patient, giving like 1.6%. There was no reoperations at the local site or even the cervical side. The treatment required no treatment required for pain location. And he did a questionnaire for the patient satisfaction, almost 97%. They were happy with the local harvesting. Outside the Alencastre, there's a nice study that was done by Pitson. It's a biomechanical study in 14 cervical function unit specimens. Basically, he took a 5x5 core of a millimeter from the cervical vertebrae, and he did the biomechanical compression, and he found there is no weakness happen to the fusion at the index site or even at the vertebra. And this stimulated others to think the same way. And O'Neill had something similar. He published it this year in Global Spine Journal. He had 12 patients underwent SDF, used autograft obtained from the same technique that was described before. And he got it from the vertebral body, and he filled the graft, almost half of it with it to improve the fusion. His fusion rate was almost 100% at 1 year, and there was no local complication from the cervical spine for this. Now, is there any evidence between the different cervical interbody grafting? This is a good paper by the spine section group of WNS and CNS. Show there is a good evidence, class 2 evidence that autograft and even allograft, they had up to 80 for single level, up to 70% in 2 levels of fusion. The titanium cage has nearly similar but slightly inferior result. Peak also had a class 3 evidence of more than 90%. Carbon fiber did not have a good fusion rate, as well as the PMMA. The answer question if the surgeon factor has important in the outcome of donor experience or technique is different. They also came with the conclusion that BMB, which is off-label for cervical spine now, has a very high complication rate, up to 30%, which is basically due to localized edema, which is not the current practice for fusion. If you, in comparison studies by Nordic, he did a systematic review of 146 paper of more than 10,000 patients of 1 or 2 level SDF. This study was basically used to answer the question if bone infusion or the method obtained, is it different between the other used materials? And to jump to the conclusion, this is their table, which shows the autologous group has 90%, and others, the allograft, they have the same number. If we go to their data, up to 3,000 of patients of the 10,000 used bone graft, but the majority they had other alternatives, and the bone used again almost 4,000 used autologous, and the rest used other agents. So the trends now, it's although still autografts is the gold standard, it covers everything, provides cells, matrix, and stimulation for bone fusion. There are promising new graft technologies coming in the literature and in practice, which eventually will have a good biological stimulant for bone for fusion. The cost is a problem, and this is a table shows that autograft is priceless. It's zero compared with the rest of the surgical disposable you're using. The peak, for example, is more than $700 US. So there was a less use of bone graft from Alencastre due to the complications that's been still significant. There are some issues about the market-driven practice using cages and expandable cage or for anterior surgery, and then usually it's filled in most of the cases with alternative bone material. This can be a problem in the low and mid-income countries, especially with the economic problem nowadays. In most of the cases, the patient might not have to cover this, and usually his insurance coverage, but sometimes the patient might have to pay of the expense of these expensive alternatives. I would conclude that still autograph is the gold standard for cervical fusion. The alternatives are acceptable if there is a high risk of complication. When autograft is limited in supply, and the acceptable rate of fusion may be achieved, like doing a single level fusion. Donor site complication is less than previously reported, especially with the revised technique and MIS retrieval of the bone from the Electrophysiology. The future combination of materials might result in expression of the same component of the autologous bone graft in terms of giving a solid fusion, and we hope that the cost will be affordable. Thank you very much.
Thank you, Saleh, for this excellent overview. You really touched all the issues relating to this topic. I'm gonna launch your questions. Just a moment. So I consider two questions.
Yeah.
Or sorry, three questions. Can you read them, please?
Yeah. Actually, I wanted to know the experience of the participant, but it can be turned like a question. For a single level, for example, C5-6 disc prolapse, what material you use the most for STF? Autologous bone or allograft, PEEK, titanium. So these are the four options.
Right. And your second question?
The second question, the reason for using autologous bone graft, the complication from the graft site. I don't see the rest.
Okay. Prolonged surgery, higher local complications.
Yeah.
So the decision for your selection is patient choice, surgeon choice, price, or company-driven reasons.
Yeah.
Okay, a couple more seconds to vote. Okay, so these are the results. Most of the people at least here in this cohort of participants, they use titanium as a disc replacement. The reason for not using autologous bone graft, most of the people, is due to higher complication from the harvest site.
That's a reasonable answer. Yeah.
Although, as you nicely said, there are new techniques that can lower this complication rate. And the decision for your selection is, most of the people here think it's really surgeon choice and option, and not really much the company-driven reasons. Okay.
I agree.
Okay. Thank you.
First
so
question,
I think
first question, I would hope to see the upper two has more
yeah.
number. Yeah.
I think it depends also where you are practicing, which part of the world you are practicing.
Yes, I agree.
So we need to move on, and for next lecture, I'm inviting my good friend Avelino Parajon from Madrid. Is the spine surgeon with most sex appeal that I know, and we have been doing education events, real ones. And Avelino is head of spine surgery from University Hospital Ramon and Cajal. He's head of neurosurgery in La Milagrosa Hospital in Madrid. He collaborates profusely with the AO Spine. He's UCMIS director and regional program director for Europe ISAS. Avelino, please go ahead. Avelino? Yeah, thank you.
Hello, Oscar again, and good afternoon to everybody. Thanks to Dr. Alves and to Dr. Bansal for giving me the opportunity to share my ideas about the utility nowadays of cervical plating in the treatment of degenerative cervical spine condition. So if we take a look to the timeline evolution of the cervical spine, we can clearly see that in the last century is where it had a real development, like almost all surgeries. And this is related or parallel to technological, pharmaceutical, and anesthesiological advances. So we can see that in the 50s, and we know that Smith Robinson and Koller were the first fusions done at that decade. In the early 70s, the first cervical plating was published by two Spanish orthopedic surgeons, Orozco and Llobet. They used the so-called ASIF plates. I think it's quite well known all around the world, and especially in Spain. And in the next 2 decades, plates were improved, reducing the profile, using new materials, and easier locking mechanisms. So Caspar plate was developed in the 80s, and a decade later, the Synthes plate show up in the market, and the Synthes plate did not need it anymore by cortical screws like the previous plates, as a titanium expansion screw was designed specifically to affix the screw rigidity to the plate. This is the well-known Koller, and his famous autograph surgery for interbody fusion. He developed this technique probably because he saw a lot of hyperflexion cervical spine injuries in surfers in Hawaii, where he was practicing. And he also is famous because he helped as a surgeon to the people who was injured in Pearl Harbor attack. So with the Koller technique and the Smith Robinson, very good clinical results were obtained. So many people can ask why we do need some plates, or why were they added to ACDF. So early on, some papers showed the value of plating to gain better fusion. And even in recent papers, we can still see this utility. So this is a meta-analysis and from 2018. And in this paper, the authors show the biomechanical advantages of plating the cervical spine. So we can see that ACDF with anterior plates fixation is associated with lower case subsidence, and also is associated with increased fusion rates. So we see the ACDF with plates is also associated with better neck pain outcomes. So plating can provide better radiological and better clinical outcomes. And there's another meta-analysis that our good friend Hartl and his group from New York, and here he showed, they found that regardless the number of fuse levels, and even regardless what type of surgical technique they use, ACDF or corpectomy, the use of anterior cervical plating significantly increases fusion rates. So what do we know in terms of real evidence about adding a plate to anterior cervical disc fusion? For one level, we know that ACDF, in ACDF, the addition of a plate reduces pseudoarthrosis and reduces the graft problems and helps in maintaining lordosis. But we also know that this alone does not improve the outcomes. Of course, we need a very good decompression to improve the outcomes. For two levels, we know the addition of plating in ACDF also even improves arm pain. This is quite curious that there's a lot of papers related to that. And also we know that this does not improve outcome alone. But anyway, all these statements are with very low degree of evidence. So by now we can think that plating is fantastic and is something that has no complication. Well, as we all know, there's nothing without complication in surgery. And one of the most frequent complications surgeons see in anterior cervical surgery is dysphagia. So we know that, and this is especially in female, and more frequent in multiple cervical levels. And so 50% of patients can have dysphagia in the first month. And unfortunately, cervical plating increases the risk for postoperative dysphagia. And also, it can increase the probability of adjacent segment degeneration, as we can see in this recent study published in the Global Spine Surgery in 2018. There's another very interesting publication early. This is from 2005, and authors show a positive association between plating and adjacent segment formation of osteophytes, as we can see here in the screen. They said that probably you can prevent it by leaving a minimum of 5 millimeters between the border of the plate and the adjacent level disc. So, for example, this is something that we try to do when we use a plate, and this is a case we have a 52-year-old electrical technician with a long history of neurological symptoms, and we can see the patient has two disc herniations. We could discuss here again if anterior or posterior approach, but this is not the matter of the lecture. And in this case, we decided to do an anterior approach with 2-level ACDF, as trying to save this distance between the plate and the adjacent levels. And as you can see, there's a 2-year or postoperative follow-up. There's no sign of formation of osteophytes in the adjacent level. So probably a good technique, a good surgical technique, paying attention to these details, is the reason why some recent studies, like this one from 2019, show that there's no higher incidence in adjacent disc herniation, even in patients with cervical plating treated with Smith-Robinson, that, as we all know, is a technique that can achieve a very high rate of fusion. So we can say that the main disadvantages of plates are prolonged surgical time, increasing the risk of blood loss because we need to do more dissection, and of course, increasing the risk of dysphagia because of the profile and because we need to retract the esophagus for longer time, as we are adding one more surgical step, and also, of course, the possibility of adding the risk of damaging another structures like the carotid artery. That is why in the last decade, additional methods of fixation to these cages were developed, trying to avoid these complications of plating. And as we can see in this picture, there are some new cages designed with several screws to fix the cage instead of using plates. In this meta-analysis, the authors tried to compare the clinical and radiological results of these cages versus the traditional plating. And what they found is that the clinical results were very similar in terms of the Japanese Orthopedic Association score and also neck disability index between the two groups. This is no surprise, as the most important thing for improving the clinical results probably is especially related to neurological symptoms, is related to a very good decompression. And we can achieve a nice decompression, as you can see here in this postoperative MRI when we are using these zero profile cages. These authors also showed in this meta-analysis that zero profile cages have less adjacent segment degeneration possibilities. The zero profile groups show a significantly reduced incidence of postoperative dysphagia and also significantly reduced intraoperative blood loss. But surprisingly, also these cages can improve the sagittal balance in terms of improving the C2, C7 lordosis. So that's why in the last decade, almost all companies in the market developed different types of cages with screws, and some of them made of PEEK, other PEEK in titanium, some PEEK titanium, and some of them have 2, 3, or 4 screws. And our clinical practice has changed significantly So I review my personal cases I did in the last 4 years in 2 hospitals, and from 156 cases in which I did the anterior cervical fusion, I found that in 140 I used cages with screws, and only 16 cases I used plate, and this was cases with corpectomy. Obviously, the cases in the left were not included. These hybrid cases, these prostheses, MIS decompression, and posterior, and so forth. So the next question is, if we are using these cages, and this is the why Oscar and we talk about the utility of this lecture, is ask the surgeons, is there still a place for the cervical spine, or maybe we have to use the plates in these other type of surgeries, as we can see in these cartoons, no? So we still use clearly these plates in reconstruction after extensive surgical resection in tumors like this chordoma that required anterior and posterior approaches. Definitely, we still use plates for instability and to improve fusion in cases of cervical fractures. But what about degenerative conditions? So also using zero profile cages in multi-level cases like this in the left, in which we put four cages, is possible in some of these patients, like the two ones I'm showing in the right. Sometimes it's really difficult to put all the screws that you need to fix the cage because sometimes the inclination, the mandible or the chest can difficult the trajectory. And some authors say that it may influence rigidity of the construct in multi-level cases. And some authors has postulated that even a lower rate of fusion can happen in this patient. And on the other hand, we know that that we have a very good evidence that in these cases, using plates, we can improve the sagittal balance, and also we have a very high rate of fusion with a low rate of complication. On the other hand, there's one very recent study from Rush University published last year, in which the authors made a prospective comparison between one level plating versus one level without plates with this type of cages, zero profile cages. And what they found is very interesting, because they found no significant difference in radiological and in clinical findings related to dysphagia. It may be that being aware of this potential complication and with these new materials, with low profile plates, in case of 1 or 2 levels, surgeons can be able to decrease the rate of postoperative dysphagia using a very delicate surgical technique. In general, we know that no matter what surgical technique we use in the cervical spine, fusion is achieved in a high rate of percentage, as we have seen in the previous nice lecture. And but there's still a percentage between 2 to 3%. We see in this publication 1.3 to 3.9% is the interval of confidence for 95% of pseudoarthrosis rate. So still we need some type of thing that we can use in the surgeries to improve this fusion rate. So based on this, all the things that we have commented till now, what I think really is first that I would recommend a plate for degenerative disc or for degenerative cervical conditions. First, based on surgeon's preference. Why? Because I think the experience of the surgeon and of the team, as in many other surgical techniques, is something that can definitely reduce morbidity and complications. So if your surgeon is very confident using plates and he has a delicate technique, probably he can be able to lower the rate of this possibility of dysphagia. I will say that cervical corpectomies usually used for myelopathies need an anterior plate, either if you use autologous bone graft or if you use this type of expandable cylinders. Very nice that a lot of companies have now. Pseudoarthrosis after using a cage or with or without screws is definitely a good indication. In some cases, just putting a plate and with no further surgical step can improve the rate of fusion. Cases in which we have done this replacement and the patient had neck pain and instability due to subsidence or dislodgement of the prosthesis are also a good indication. And as we discussed previously, probably multi-level, 3 or 4 levels, using a plate can be a better option in terms of trying to get better fusion rates. Also, some surgeons probably will argue with me that for 3 or 4 levels, in some cases, a posterior approach can be a very good indication, and probably Oscar will be happy to hear that, as he is very good in performing this type of posterior MIS decompression for cervical myelopathies. No? So thank you very much again for the invitation. Greetings from Madrid, and stay safe.
Thank you, Avelino. I really enjoyed the presentation, very complete as always. I'm gonna launch your inquiry. Let me see. So, do you want to read the questions, Avelino?
Yeah, the first question is if cervical plating in anterior surgery is not related to increased fusion rates, improving sagittal balance, a quicker recovery after surgery, or if it helps to improve neck pain outcomes.
Second question.
And the second question is a good indicator for indication for anterior cervical plating is 1-level soft disc herniation in young patients, multi-level anterior surgery in cervical myelopathy, foraminal disc C71, or big anterior osteophytes.
Okay, so pretty straightforward, and your lecture was quite clear. So just finishing 1 minute voting. And here are the results. So for the first question, is not related to improved neck pain outcomes. Can you comment on this?
Yeah, this was quite a trick question, because obviously many people can think this is the right question, but we have seen that is a little bit of discussion about this, but we don't know why. Definitely the evidence has shown that it can improve the neck pain outcomes, probably because it decreases the rate of subsidence. And the right question is a quicker recovery, because obviously if we add one more step, the recovery can be not so quick. You know?
And especially for sportsmen and people playing rugby or this kind of it's probably the good option. So for the second question, 100% of the voters agree that multi-level anterior surgery is a good indication for use of the plates, and you made it nice clear. Okay, thank you, Avelino.
Thank you, Oscar.
So to finish our webinar and close it with golden key, I call Jeffrey Wang, that I have to especially acknowledge, because I gave him a very archaic topic to develop, that he accepted immediately, and we're gonna have his vision on the use of clamps, hooks. Are they obsolete, or they are still useful in modern surgeries? So Jeffrey, please.
Great, thank you so much, and thank you for inviting me. I just want to make sure, since I have 2 screens, that you see the appropriate screen.
That's fine.
It's good?
That's a good one, yeah.
Okay, so thank you so much for having me. I'm honored to participate with such a great panel of speakers. I'm gonna make up some time here, because I think my talk will be a little bit less than the time allotted for me, but do wires, hooks, clamps still make sense for cervical spine fixation? And these are my disclosures, and I don't think this is going to affect anything of what I say. But I think when I look at cervical cold fixation, I think we initially had early fixation, like wiring, hooks, and clamps. And then we came up with screws, plates, and rods. And nowadays, we don't really use the wiring, the hooks, or the clamps that much anymore. And when I go to national meetings or international meetings and I look at scientific presentations, I look at biomechanical presentations, and I go to symposia, I go to the exhibit hall, I'm seeing things like this. I'm seeing robots, navigation, all the new technology. And it's hard for me to find any clamps, wires, or hooks when I'm going to the exhibit hall. And I have to wonder, are we still teaching these techniques? And I think it's something that, could it be a lost art form? And so I'm going to talk about two things. I'm going to first talk about hooks and clamps, and then I'm going to talk about wiring, which I still think has some usefulness. But when I look at hooks and clamps, I can tell you that when I review the literature, I realize that this is mostly historical in the sense that, you know, they came out many, many years ago, and there's a lot of different devices. I don't think I've ever used sort of a clamp type device. I've certainly used hooks. And I found some of these x-rays from the internet. And I look at just some of the evidence, and it's almost like any new technology. When you first come out with it, there's maybe a higher rate of complication, higher rate of dislodgement of the hardware. But as you see sort of the later literature showing that the complication rates are much lower, and people get used to that type of technology. But then you get to a point where it gets a little bit outdated. And I can tell you that when I look at the literature on hooks and clamps, it's pretty old. I found these pictures from the internet, and all the pictures that I found were pretty old looking, such as what you see here. I really don't see any contemporary designs. And I think the literature shows that some of the more modern fixation is a little bit stronger and superior to hooks and clamps. And then I Googled cervical spine clamps, and I don't recognize any of these things as being clamps. I Googled cervical spine hooks, and again, there's nothing here that looks like a hook to me in the way I look at it. And so I think these are largely outdated. And when you look at sort of newer literature, it basically says that wiring and interlaminar clamps have fallen out of favor because of the development of newer and superior fixation. And so we have to ask ourselves, is this more historical? I do think that there could be some uses for it. Certainly, if you can't place a screw, or if you have a pseudoarthrosis and the screw just won't hold, maybe a clamp would be an alternative. But I don't use those a lot in my practice. However, when it comes to wiring, I think it's something that is still useful. And I think it's something that we should be very careful to teach our residents and fellows, because there's some validity, I think, to using wiring. Now, I will say this. Now, I am a bit biased because I did my spine training with the late Henry Bowman, and Dan Rue also trained with Henry Bowman, and this is the classic Henry Bowman triple wire technique. And I think that it's hard for people to learn this nowadays because we have screws, we have rods, and things like that. But a few things, you know, his original technique that I learned from him was basically putting a figure-of-8 wire down before you put your grafting in. And a lot of people think that the triple wire technique, excuse me, is just this, or it's with the grafting. But the way he originally described it and the way he did it in his practice was basically putting two wires in, basically putting the wire in first and then putting a second wire in to hold the bone grafting. And when I look at this, it brings back fond memories, but I also use some of this in my practice currently. Now, here's a very old slide from Dr. Bowman, and in some situations, it could be very useful, right? I can tell you that if you do the triple wiring in the appropriate manner, it's very strong. And so you have good fixation. Sometimes the lateral masses is what you see here. This lateral mass is very small. And so oftentimes you can't get a very good screw in C7. Now, a lot of people will say, I don't stop at C7, I go down to T1. However, if you do stop at C7, maybe putting a shorter screw and then using the wiring techniques might give you enough stability so you don't have to go down to T1 just for fixation. Other people go down to T1 routinely because they don't want that transitional segment. And so, but again, that can maybe help you. I've used this in pediatric patients. I can remember thoracolumbar fractures in young children where I couldn't put screws in, and I use this technique. It's very, very strong. And so it's something not to forget. And the other thing that I like about this technique is the biological fusion. When I look at these graphs that are, now again, these are autogenous grafts that Dr. Bowman used. And we don't use autogenous graft, but when I look at this grafting and I look at the massive amount of structural bone that's here in the back, I just know biologically it's probably going to have a higher chance of healing. And so I oftentimes will use it in addition to plates and screws and rods when I want to get more biology here, because, and I won't use autograft anymore. I'll usually use allograft, but it's very strong and it's also a little bit more biological. And I'll show you some examples of that. Now, here's some situations where I still use wiring and I find it very valuable. Here's a patient that has C1, C2 instability. You can see that they're flexed forward here and they subluxate and they reduce here. Now, even when I'm doing a C1, C2 fusion and I'm putting in screws and rods, I will still use the wire to do the reduction. And I think it's very valuable because if you look back here, oftentimes when you're doing this fixation and you're doing the reduction, you extend the neck a little bit and the occiput blocks your access to C1, or it's a little bit more difficult to work. What I can do is I can position the patient in neutral where I don't have to extend the occiput, so the occiput gets out of the way and allows me to put my screw fixation in C1, C2 a little bit better. But what I'll do is I'll use the wire technique underneath C1 and around C2, and I'll use that to reduce that subluxation. And I don't have to reduce it just with positioning. So I can keep the patient neutral, and then I can just get the occiput out of the way. It gives me better access there, and I can reduce without positioning. And once it's reduced, then I can put my screws in and get fixation. And so I do think it's very valuable, and I use it on almost all of my reductions. The other thing is the biology. You know, when you're doing a reduction such as this and you've got the wire in, you can wire in a graft. And in that sense, you get a really good biological fusion. Now, if you're doing a C1, C2 fusion, you can certainly put bone graft over the lamina that you decorticate. Some people talk about, you know, decorticating the facet joints and putting in some bone graft, but that's a pretty small area to get it to biologically heal. If you put in this type of grafting, and even if you graft the facet joints, you could put graft here and you structurally put a graft. This is very, very strong. It's very biological. And then you can assess the fusion a little bit better because it's really hard for me to assess a fusion here. If I'm just laying particulate graft here, sometimes I don't see it as well. But if I put a structural graft here, as I see it mature, I can sort of see that graft come together and I feel more confident that biologically it's healed. The other thing is that when you're doing the technique, it's very important that you don't pull dorsally. When you're putting the wires in, you pull out laterally to get that really tensioned appropriately. And then on top of the grafting, or on top of the wire, I put these grafts in here. And again, biologically, for me, it just makes me feel more comfortable. You do get some pretty strange x-rays though. If you're not used to the wiring, you'll get x-rays like these and it's hard for you to really assess. And if you're not used to it, it looks a little funny. But in certain situations such as this, and I know Dan Rue uses cable a lot, but now we're looking at cervical deformities and potentially you can take those wires and allow you to get a better reduction and get some more sagittal balance. And we all know that we want to restore at least the regional balance. And I think there's a lot to be said. Like if you do, even if you do a laminectomy, even if you get this angle between C7 and T1, sometimes that allows you to get a better correction and overall sagittal balance. The other area where I think biologically it helps me is when I'm doing occipital cervical fusions. And I don't look at this as being a strong fixation, but I look at the biology of putting these grafts from the occiput down to the cervical spine. And so I will still use this in addition to using plates and rods, because when I'm doing occipital cervical fusion, I think it's hard to get bone here. The occiput is very cortical. There's not a lot of cancellous bone. And this is a pretty long way. And there's a lot of high stress here. And a lot of times you get non-unions, and sometimes these patients are asymptomatic. So getting a non-union here isn't so bad. But for me, if I can, in addition to my normal fixation, I can put this biological fixation here with the wiring techniques, I feel a little bit better. And here's an example of where I did, this is a patient with cranial settling, could not get screws up here in the C1 or C2. And I've done my proper fixation here, but I also wiring grafting, and I can assess the fusion here. And I think I get a higher healing rate when I'm wiring biological grafting from the occiput down to the cervical spine. Here's another situation, sorry, where again, doing an occipital cervical fusion, when I put this bone graft in here, and oftentimes I'll use other types of more powerful bone grafting, even if it's a bit off label, because I think this is a very difficult area for it to heal. But even when I do that, at least I can see this good solid piece of bone forming here, and allows me to, I think, get a better fusion and allows me to assess the fusion a little bit better. Here's a patient that had a C1, C2 fixation, and they develop a non-union. And so here in this situation, it's oftentimes hard to revise a screw because the screw has cut out or it's widened the hole. It's hard to get a bigger screw in there, but you can always revise wires. So here's a C1, C2 where I basically was able to put a translaminar screw in because the pedicle screws at C2 were too big and they were gone. And I couldn't, I could get one lateral mass screw in C1 and the rest of the screw holes were just too big. So in order to salvage this, I was only able to get one fixation at C1, one fixation at C2, but I was able to wire in a structural graft. So it's just another area that helped me, I think, get more and better fixation. The other thing is that even when you do a laminectomy, if you're doing a long laminectomy and you're putting in lateral mass screws, pedicle screws, and rods, you can still put these wired grafts in here to give you extra fixation. In osteoporotic patients, I'll oftentimes do that. So here's a rather long cervical decompression fusion. I've done a laminectomy. I couldn't get pedicle screws in because of the high riding vertebral arteries into C2. So these are more PAR screws. But in this patient, I was able to wiring the structural allograft fibula from up here at C2 all the way down to T1. And even though I don't have the spinous processes here in the intervening segment, I feel a little bit more comfortable not only with my fixation, it protects my fixation, but from a biological standpoint, I'm wiring grafts in there, which I think will increase the chance of healing. This is a patient of mine that was on that Norwegian cruise liner a couple years ago that crashed up in the European area, and he sustained a C1, C2 complex fracture. He had a previous posterior and anterior cervical fixation, and so had some injuries up here. And I basically extended the fusion up the occiput, but again, I'm wiring in these grafts from the occiput down to the cervical spine. And you can see I've wired 2 grafts in here, and this one looks fantastic. And again, it allows me to assess the fusion a little bit better. And so I do think that there's some uses for the wiring. You have a pretty unstable segment and you want to put in screw fixation. I think that that's great fixation, but if you can wire in from the spinous processes above to below and wiring some biological grafting, I think that it can really help you a lot. So in summary, at least in my practice, I think the hooks and clamps have limited uses. There might be some situations if you're an expert at it and you might still find it quite useful. But I do think cervical wiring is still very useful in certain situations. And I would encourage you to teach your fellows and do a few of these with them at the very least so that we maintain this technique. With that, thank you very much. It was an honor to participate.
Jeffrey, thank you. I was not really disappointed by my challenge. You did really a wonderful lecture. It's only a master can do it, and you acknowledge that you still use this kind of old-fashioned technology. So really well done.
I had a comment. I would like to thank so very much, Jeff. When you operated on, as he said, in pediatric cases, particularly at the junction, occipital-cervical junction for a multiple of disease, even you have, as Jean Dubousset that did in past, baby Cottrell Dubousset, you know, there is absolutely no room to insert anything. So wire can be very a salvage technique. And I totally agree with you, Jeff. This is it's very important because young kids, young fellows doesn't use any wire or stuff like that. But they must learn from this type of technique because it's a salvage technique. I agree. And I thank you for your honesty.
Sure, thank you.
I have another comment about electrophysiology surrounding.
Philip, just a moment, please. Let me launch Jeffrey questions.
Yeah.
Sorry. So Jeffrey, can you read your questions, please?
Yeah.
Jeffrey?
I apologize for these questions. It was hard to think of questions about this topic. I think these are pretty simple, but when utilizing some laminar placement of hooks, wires, or clamps, The intrusion in the canal caused by the placement of these devices typically leads to which common clinical scenario? And really, for people that are not used to doing this, you have to do it right so you don't damage the nerves. But basically, and this is a pretty easy answer, I don't really see any neurological issues, but you have to be careful. You have to be very careful. And that's probably the most important part of the technique, is how to pass these without damaging the spinal cord, because you're dealing with the spinal cord. And the second one is, when performing cervical fixation in an osteoporotic patient, which of the following is most common clinical scenario? And really the answer is that even if you have osteoporotic bone, the spinous processes can still be quite strong. And putting these wires in osteoporotic patients, if you do it right, I really don't see these cut out. I've seen screws cut out, but I haven't seen these wires cut out if you do it the right way.
Right.
So I'm sorry, I've kind of answered the questions as I asked
you
them.
you did a nice job. Thank you. Okay. So Philippe, so now we have some more time for discussion. So, you know, please feel free to make questions.
Yeah, I've been impressed by Dan and Takashika about examination for myelopathy and radiculopathy. And my question is, sometimes the situation remain really confusing. So I'm getting back to you guys. Are you using systematically or not electrophysiology, and when do you use electrophysiology before surgery? Because electrophysiologists put pressure on, telling us that it's really, really, really important to do that. But in my practice, it's very rare, and particularly during surgery, I'm not using any monitoring for spine surgery, cervical spine surgery. So, my guys, so do you use?
So this is an open question for all the.
Yeah, exactly. So then
I use EMG nerve conduction studies when I'm trying to differentiate, and I think somebody might have a double crush, and I'm not positive that they might have both a carpal tunnel syndrome or a cubital tunnel syndrome, as well as a cervical pathology. So I don't use it in, I would say the majority of the patients, I don't use EMG nerve conduction studies. As far as intraoperative monitoring, I think anybody that you're doing a deformity correction or somebody who's got myelopathy, you should use it. And then everyone else, it's optional.
Because I think that when I so worried about this patient is suffered from the motor neuron disease or so. So in these cases, EMG is very useful. And talking about the spinal cord monitoring during the surgery, high cervical, very risky cases, I think that the D wave is most important to know the the damage during the surgery to the spinal cord. Yes, and the MEP is not so useful, only at the high cervical areas. I think like that.
What about you, Oscar?
Well, to be honest, Philippe, we don't use much in intraoperative, only in more complex cases, of course, myelopathy and higher cervical cases. As a diagnostic, I'm a little bit like Dan. If you suspect that there is a concomitant entrapment, I tend to do it, and probably to offer the easiest surgery to the patient before I go and do a next surgery. In that case, I feel the patient is a little bit problematic. Sometimes to know if there is already a radiculopathy before you operate the patient is sometimes a good thing to have if they become a little bit problematic in the future.
Another comments about Jeff. Jeff showed us a lot of autograft, particularly in the heavy case, etc. So I joined him too. I mean, a lot of guys use homograph rather than autograph, but I think that there is indication for autolesions or autograph for particular heavy cases like neurofibromatosis, for instance, the deformity in young kids, you know, using a big graft, because the dystrophic of the bone is really so bad that you have to do anterior and posterior approach fusion. And Jeff showed us a lot of autograft bone for failure case or second stage surgery. So I mean, there is indication to Jeff. Any comment about autograft rather than homograft?
Yeah, I certainly think that autograft is there, and it's the best biological thing. And you know, if you get it to heal quickly, you don't need as much biomechanical fixation. So there is about the speed to healing is very important. It's just that it's really hard to use autograft here in the States. And Dan and I both trained with Henry Bowman, and we both have taken autograft fibula. We've taken huge chunks of the iliac crest. So I can tell you these things healed, and Dr. Bowman was really, you know, pretty strongly in favor of doing it. It's just hard for me to do that to my patients nowadays because, you know.
Jeffrey, how long it took to do those cases? How long?
Well, it's been so long, I can't remember, but we used to take the fibula and I tell you, they would heal. Autograft heals great. Dan, I don't know if you want to comment on that, but you probably have taken a lot of autograft with Henry Bowman.
Oh yeah, I you know, taking a fibula, and I used to think that the taking a fibula didn't hurt because patients never complained about pain from their fibula or iliac crest graft site. And then I remember my first 2 cases in practice, I took the fibula and the patients complained about pain in their leg for months and months and months. And so I called up the nurse and I said, how come Dr. Bowman's patients never complained about pain from their iliac crest or fibula site? And she said, are you kidding me? They complain all the time. They just never complained to him. And so that's why you never heard it, because they would never complain during clinic because it was Dr. Bowman. But of course, when you're like the rest of us, our patients complain to us. But if you're Dr. Bowman, they never said anything was wrong. They say, oh, thank you so much for treating me.
I got exactly the same experience with Jean Dubousset because I was operating a lot of scoliosis of Jean Dubousset. So the patient was getting back to clinics of Jean Dubousset, and he have a look on the iliac crest. He say, Philippe, there is no scar on the iliac crest. So how did you do the fusion? I say, no, sir, just the decortication was enough. Don't do that. Never. You know, exactly the same experience with all guys. It's fun.
Okay, any further question or comment? You know, to conclude, I will go and proceed to conclusion. I have to thank Anna for her great support for this webinar. Actually, nobody noticed it was her first webinar, and I know how hard it is to work with surgeons. Of course, thank you to all participants. They are the reason why we are doing this kind of webinars, and due to Corona times, I think they are here to stay. On the 5th of December, we'll have a next CSRS Europe webinar. The topic is cervical spine practice in low and middle income countries, which I think it's a very important topic because we tend to have a lot of discussions on the first world practice, and Africa and Asia, it's a different issue. And of course, I'm grateful to the entire faculty. They were really brilliant to address such difficult topics. I know something that looks simple, sometimes is not. So you did really a great job, and I thank you all. Philippe, do you want to say a final word?
No, I'm very glad to see you all, guys. It's fun to see you. I would prefer to be with you, man. But you know, anyway, having look on you, learning from you, it's a very good experience, and I thank you guys to be there and healthy, and I hope a very good good hand of yours with a healthy family around you guys. Stay in good chat.
Thank you.
It was great to be with you. Very nice webinar.
Thank you. Bye bye. Thank you, guys.
Thanks.
Keep safe. Stay safe. Thank you. Bye bye.
Merci.